So coming back to my topic, I shall be discussing how to critically appraise a journal article. Most of us are aware that the social media gives us medical advice on a minute-by-minute basis. And most of us are also aware that this is mainly fake news. That is, it is not trustworthy. So, what will we do when we come across a high-index journal or an eminent personality in a particular field or a prestigious institution or a combination of any of all of these that comes out with an article that literally makes a claim that grabs our eyeballs? So how do we critically appraise it? And now with the era of big data, which is actually a great game changer, where the number of participants is in the tens of thousands, it becomes all the more imperative that we critically appraise that article. So I shall give you few pointers, very few pointers, I cannot discuss all of them today, about how to critically appraise a journal article. The first one is the study design appropriate? So I shall give you a few examples. This is a study by Zemansky et al., which came in the prestigious American Journal of Ophthalmology in May 2018. It aimed to evaluate the relationship between the dietary levels of omega fatty acids with dry eye disease or meibomian gland disease. By design, it was a cross-sectional study. And this study concluded that the dietary consumption of these omega fatty acids showed no association with dry eye disease. However, the study also went on to conclude that moderate to severe consumption of omega fatty acids is actually protective against the meibomian gland disease. So now let us examine this design once again. This is a cross-sectional study. So this means that we are measuring the dietary level of omega fatty acids and the signs and symptoms of dry eye or meibomian gland disease at the same point of time. That is, the same point of time is the important thing. So we cannot say which came first, the disease, dry eye disease or meibomian gland disease, or the dietary alteration in the omega fatty acid. So we cannot claim that omega fatty acid consumption in moderate or severe quantities is protective against meibomian gland disease. So this is a classic chicken and egg situation, and this kind of design is not appropriate. Let us look at another design or another claim. Diabetes may raise the risk of primary open-angle glaucoma by 36%. Most of us in our clinics or in our OP may have seen people with primary open-angle glaucoma, and they also have diabetes. So is this a clinic-based phenomena, or is it actually reflected in the general population? But when we look at their first-degree relatives who are age and gender matched, many of them have diabetes but no open-angle glaucoma, or many of them have open-angle glaucoma or not diabetes. So how do we actually know that this claim is true or not? So for this, we have to perform many of the randomized control trials, which are actually a special type of prospective cohort studies, where the exposure is diabetes mellitus and the outcome is primary open-angle glaucoma. And then we have to perform a systematic review and meta-analysis using the statistical parameters like the odds ratio or the relative risk or confidence interval, and then see whether this claim is valid or not. So Zhao et al. Made such a study. They did a systematic review of some of these all of these randomized controlled trials, and then published their results in the prestigious PLOS1 journal. And now, so we know now that it's for true that diabetes mellitus is a risk factor for primary open-angle glaucoma. So in the hierarchy of evidence for intervention studies, unsystematic clinical observations occupy the lowest rung. So it is like saying ivermectin is useful in the management of COVID-19. So this is just a physician's observation. But if randomized controlled trials are available, and if we conduct a systematic analysis, and then only we can believe that ivermectin is actually useful for COVID-19, and then we can apply it for our clinical practice. The second pointer I want to highlight today is to look for bias in the study. Now, bias is one factor which can entirely mar a study. The materials and methods section of any study should be so well written that another person who wants to replicate the study should have absolutely no difficulty in doing so. The best way or the easiest way to look for bias is to look for industry funding or the commercial affiliation or interest of the author who is endorsing a particular product in the study. So if we look across many of the articles about minimally invasive glaucoma surgery, we can easily discern the bias in many of these studies, not all of them, many of these studies. Look at the allocation and look, if it is a randomized control trial, look whether the allocation does have the random basis. Is a random number table used or is a computer used to generate the random sequence? Then there is a higher degree of evidence towards the result. Allocation concealment. Was it done using has that method of allocation concealment been explained very well? Then again, if it is not, or if you have some doubts, then the degree of bias should be evident. Who all were masked in the study? People who are participants in the study are usually masked. The study personnel may be masked. The outcome assessors may be masked. But sometimes you are not able to mask certain people. Has the study given you convincing reply or reasons why those persons are masked, and are you convinced? Then only you can understand the bias of the authors of the study. Dealing with incomplete data is very important. The study should always give us a flow diagram about the number of people enrolled, why some of the people were excluded, and then how many were randomized into each group. How many were allocated into each group, and how many were lost to follow-up, with reasons for each of these. And finally, how many people were taken for analysis, and is the number equal to the number taken as the sample size or slightly higher than that? If we do not follow the loss to follow-up or what happened to the loss to follow-up, then there will be problems. Like, the ocular hypertension study was done at the same time as the European glaucoma prevention study. But the OHTS study is considered a landmark, while the EGPS is practically forgotten. That is because in EGPS study, the number of people lost in the treatment group was 32%, and in the control group was 23%. And later on, when they tried to find out what happened, they found very, very later on, when EGPS was thought to be nearly a failure, they found that those in the treatment group had high IOP. And the EGPS finally came up with a conclusion that a placebo also significantly and consistently lowered IOP. So a placebo lowering IOP, that is, you all know that doesn't happen. So when we are dealing with bias, it is important that we should avoid bias or recognize and discuss it. But more importantly, there are many studies which are actually biased. So here I'm giving you an example of an abstract of an original article which appeared in the Indian Journal of Ophthalmology, which wanted to determine the safety and efficacy of mitomycin C injection versus sponge during trabeculectomy. In the results of the study, this study claimed that all major complications were encountered in the sponge group. And immediately it goes on to say that the mitomycin C injection may be as safe as the sponge injection. So you have all the major complications in one group, and then in the next breath you say that it is as safe as the other group. So that shows the bias of the author. And secondly, any person who has performed a trabeculectomy, or more importantly, managed a trabeculectomy after the surgery, the post-op period, would know that this is one surgery which does have complications. So saying that all the complications happened in the sponge group and none happened in the in the injection group does again show the bias of the author. Then it is important to look for confounding, the third pointer. The confounders are factors which can affect the result of the study, which are known or unknown factors which can make the study go in one or the other direction. The best way to avoid confounding would be to use an RCT. And for that, we should look at the table 1 of an RCT. This is the table 1 of ocular hypertension treatment study, and you can see how well the treatment and the control group are matched to each other. But if the treatment and control group are very, very precisely matched to each other, that should raise a red flag in your mind. So these are the common or the most important of the pointers to approach an article critically. But there are also certain evidence that we cannot find out about the conduct of a trial. These include protocol violations, like episodes of unmasking during the study, or the quality of the study procedures, how good or bad the bookkeeping was during the study. And then this whole thing, the writing of an article and the conduct of the study, and how much it reflects the study, is all a matter of faith. And faith can easily be broken. COVID-19 has told us how data falsification and fabrication are used nowadays. And most importantly, to conclude, I want to highlight that a single study is not enough to claim causality. This has to go through the rigors of multiple randomized controlled trial, a systematic review, and a meta-analysis before you can implement the results of that trial in your practice. Thank you very much for your kind attention.
Thank the Rioalumni Association for giving me an opportunity to participate in this meeting. And I have been asked to talk on NABH accreditation, mandatory or not. Before I proceed with my talk or my presentation, I would like to acknowledge the role of my esteemed friends and colleagues who have helped me to develop this talk. Thank you, Dr. Nirmal, Dr. Shashi Kumar, Dr. Rajiv, Dr. Gagan, Dr. Chandrasekhar, Dr. Senthil, Dr. Sunita Dubey, and Dr. Meena Chakrabarthi. So what exactly is accreditation? See, as an individual or a group or an organization, we always want to become better. We always want to improve. And we want to be better tomorrow than what we are today. So this is an internal level of competition. So I remember about 15, 16 years back, I built a questionnaire myself and handed it over to the staff members, asking them to assess themselves. And all of them returned a score of 10 out of 10. Even the worst performing employee claimed 10 out of 10. So I realized that this self-assessment thing is something has to be done professionally. So I approached one HR agency because they have very comprehensive established standards that was customized to our requirements. And their team spent some time along with our employees, that is external peer assessment, gap analysis was done, and subsequently the new features, etc., were incorporated so that the effectivity and the performance of the staff members were brought up to a higher level. So NABH does exactly that. It is an external review of quality based on written and published standards. The reviews are conducted by professional peers, and the whole accreditation process is administered by an independent body. The aim of accreditation is basically to encourage the organization to develop. In the process, obstacles come up, and then they again participate, and they really help the organization to overcome those obstacles so that ultimately the organization goes on to the next level. NABH also helps to scale up excellence and recognition. Regulatory compliance is something that we as medical professionals are not trained in. We do well in our studies, surgery, patient management, but still we do not know about many of these, the regulatory compliance. I'll give an example. About 2.5 years back, when this is our new hospital, and when we went for fire and safety license, they said that the railing that you see right now, this is correct, but then we had horizontal rods, and there are intricate designs, and that is not acceptable. So this actually was supervised by an architect who has built more than 100 eye hospitals. So it basically boils down to your knowledge about the statutory requirements, the various regulations, the various laws that are governing the hospital and the healthcare practice, and NABH definitely comes to your help in this regard. Documentation, I think, was very well emphasized. I was a little late to walk into Mahesh's talk, that we all document our findings on the case sheet. It helps us to continue the treatment in a more scientific manner. It is better for the patient care, and it is also very useful for medical legal situations if there was one situation. So the same documentation process also should involve the other departments in the hospital, the HR, admin, accounts, etc., again to improve their performance. Patient care excellence is another facet that is definitely helped by NABH accreditation. For example, when a patient comes to us for treatment, we treat well, do a good surgery. But if the system, if the process has not treated the patient well, starting from the security to the registration process and so on and so forth, the patient has a lot of complaints, and we need to waste a lot of time in dealing with those complaints. So basically, again, NABH helps us to set up a system to manage these issues better. So basically, there we get a recognition of our quality in terms of patient satisfaction, employee satisfaction, as well as management satisfaction. So what are the benefits to the hospital? Now, see, every other day, if you see the social media, WhatsApp, Facebook, etc., the hospitals are really celebrating their NABH accreditation, either the entry level or the eco standard. It is basically a landmark in the journey of the hospital. With the existing facilities, without going to the cutting edge, with NABH accreditation, definitely you can, it is definitely an important journey. It is a moment of honor, and that also enables you to market further. You can brand your organization, you can market it digitally or whatever means. So that is definitely, is going to help you to promote your practice and make your practice more viable and sustainable within the existing infrastructure. You don't really have to go up the scale. Now, it also benefits the management. As I mentioned earlier, we are not trained in, like when you start a practice, just out of our medical training programs, we are not really sure about how to run a big establishment, run a hospital. Even administrators. Before we had our own setup, I used to operate in a particular hospital. One of those hospitals, I told the management that your hygiene and the restrooms need a lot of improvement. Management was shocked. They said, see, we are a hospital, and this is what you are talking about. So this is where, NABH definitely comes to your help and rescue. So it basically improves your standards by application of quality tools for the management. The management also learns how to engage the staff members and align them with the organization mission, vision, and objectives, and improves patient care in all aspects. So another thing about NABH accreditation is it helps you in getting empaneled. Today, none of these insurance agencies will empanel a new hospital if there is no NABH accreditation. This is slowly changing because IRDI has given new instructions to them. And again, in terms of reimbursement, NABH accredited hospitals get 10% more reimbursement compared to hospitals which are not NABH accredited. A couple of days back, I received this picture from one of my classmates. He is in Mayo Clinic, and his hospital has been given the top one of the topmost, the best hospital in USA, out of the top 20 hospitals in USA. So there are a lot of organizations which assess the performance of the hospitals and come out with a list, and they give awards to the various hospitals. So these hospitals are guided by the benchmarking indices and indicators, which is provided by NABH accreditation. Again, it helps the hospital to scale up by setting up an objective system of evaluation and empanelment with third parties, like government, CGHS, ECHS, and so on and so forth. And it also may promote medical tourism promoters. And not only that, it helps the hospital to, with getting funding from a third-party lender. For example, the VC funding, angel investors, Lions, Rotary, etc. Because these organizations have an access to a reliable and certified information on the facilities, infrastructure, governance, and level of care provided by the hospital. It definitely benefits the employees because there is greater interaction between the management and the employees. The employees have a clearer understanding of their rights and responsibilities. And it is very useful to align the employee objectives to the organizational objectives. As far as patients are concerned, as I just now told you that it is not only the cure that you give to the patient, the quality of the surgery, quality of the treatment, but the whole process, how the whole process has treated the patient right from his journey from entry to the exit. That is important. So a patient becomes aware that he is having access to a quality-focused hospital. The patient's rights will be respected and protected. There is better counseling, so there is better education and two-way communication between the patient and the hospital. Patient satisfaction again is evaluated in various ways, and the patient participates in the care or the care decision or the various processes or investigation that the patient undergoes. So basically, there is a focus on patient safety and care. So friends, is accreditation beneficial? I would definitely say yes. It gives you better outcomes, increased efficiency, enhanced quality and safety, and reduces the risk. So for all the stakeholders in the hospital, the patients, staff, management, government, and payers or corporate sector, anyway, accreditation is a win-win situation. Thank you very much for your attention.